Welcome, everybody. Here, my mic is burning. I don't have any conflict of interest, and our healthcare-associated infection and antimicrobial resistance prevention program is primarily funded through a cooperative agreement from the CDC to the state of Illinois. So all our wonderful team that we've hired through Hectone, through a grant, it's all really originating from funding from the CDC. I guess we have some pre-test questions for the continuing education. Do I have to read through these or? Yes. Okay. They'll come back up again at the end. So this is a true or false. In 2015, the number of people treated in Illinois hospitals with C. diff infection would be more than the capacity of a large outdoor concert venue at Millennium Park in downtown Chicago, whether that's true or false. And then which of the following are priorities of the Illinois Action Plan to prevent healthcare-associated infections and antimicrobial resistance? A is infection prevention infrastructure, standards, and practices. B, assessment, treatment, and outbreak. C, antimicrobial stewardship. D, multi-drug resistant organisms. Or E, all of the above. So I'll let you guess at those answers while I talk. Here we have a snapshot of some data from our National Healthcare Safety Network. And I picked Clostridium difficile because it's the one that's most closely tied to antibiotic use. And this is very similar to one of the reports that you would see that we publish in a PDF format on our Illinois Hospital Report Card and Consumer Guide to Healthcare. We've started putting together some trend reports where we look at this over time as well. And what you see on the red bar graph is the standardized infection ratio, which is an adjusted statistic trended over time. C. diff is one of those things where we made a really concerted effort, kind of saw a little dip, but really have not made the progress that we really wanted to. And then in the table below that, we have kind of the breakdown of the number of C. diff infections, the number observed, the number predicted, the confidence interval. And this is kind of the traditional way of presenting this data. However, that doesn't really speak to everybody. It's a little bit abstract. So I've really been pushing for using data to tell a story and to kind of look at the data in another way. So considering that recent antibiotic exposure is a primary risk factor for C. diff, and that a substantial proportion of those antibiotic exposures or prescriptions are not necessary, in 2015, Illinois hospitals reported 15,476 cases of C. difficile to NHSN. And half of them were designated as community onset cases. And we know that there's likely a lot more community onset CDI cases that are not captured by NHSN. Because keep in mind, this is just in the hospitalized population. So what does 15,000 people look like? Well, this is a concert in Pritzker Pavilion in Millennium Park, and the capacity there, if you add up the actual purchase seats as well as the lawn seats, you get 11,000 people. So more than that crowd, if you can picture every year getting C. diff in hospitalized patients. I have a background as a clinical nurse, so when I think about C. diff, I think about gowning and gloving and all the extra nursing care that takes to take care of a patient with that. Needless to say, also the suffering that patient is going through. And then some other data that we get from NHSN that we've started looking at are the Antibiotic Use Module. We have a handful of hospitals in Illinois that are reporting to this module. About 12 out of 183 have reported at least a few months' worth of data. And now we also have the National Healthcare Safety Network facility survey data, which added some questions about which components of an antimicrobial stewardship program are in place at a hospital. And only 44% of hospitals have elements of all the 7 core elements for a stewardship program currently in place, according to what they put in this survey. And another big topic in Illinois is we have the dubious kind of designation of being a hot spot for carbapenem-resistant Enterobacteriaceae, or CRE. So we started the Extensively Drug-Resistant Organism Registry in partnership with the CDC Prevention Epicenter in Mariah. And since we started this in 2013, we have had 2,700 45 patients entered into this registry. And the number of events that have been reported is more than 4,300. And again, I've got some little graphs about what the resistance mechanism is. We can tell whether it's, kind of not known, if it was just depending on which reporting criteria they used, and what the specimen source was, kind of assuming that if it's a rectal swab, that it's just a screening rather than a clinical isolate. So again, we have a substantial burden of CRE. And now we have some newer national tools that are coming out, kind of playing around with different ways of looking at this data. We have the Antimicrobial Resistant Patient Safety Atlas, which, I put the link in here, and you can actually access this right now. This is something that CDC put up there. And it's a geospatial kind of a mapping representation of the data from device and procedure-related healthcare-associated infections that are already being reported to the National Healthcare Safety Network. So they've got 31 resistant phenotypes or bug drug combinations. And it's not really meant to be an estimate of burden, but it's more like, if we pull, all the Staph aureus that was reported as causing one of these types of infection, how many of them were multi-drug resistant? So it's really more that kind of data. So when we look at CRE, the national resistant, when they looked at Enterobacter ACA, about 3.5 were resistant. But then when we look at Illinois, 3.6% of our isolates that were causing HAIs were resistant. So it also gives you the ability to kind of compare the resistance pattern for your state compared to the nation overall. And then, I looked at MRSA. We're slightly better off, really kind of on par with national, at 45.4% resistant with our Staph aureus. And then with Acinetobacter, that seemed a little bit bigger jump nationally, about 54 to 56% resistant. And in Illinois, 76% of the Acinetobacter were found to be resistant. So again, that's just kind of a fun little tool that CDC is still kind of playing around with that might be of interest to some of you. And we've also done a substantial amount of work developing the Illinois Action Plan to prevent healthcare-associated infections and antimicrobial resistance. And this was something that has been going on for over a year, developing this strategic plan. And it's really a living document, but we worked really hard to gather a very diverse group of stakeholders. I think we had about 80 people give input into this, and pretty soon we'll be going through the publication process to actually get put online for all of you to read in full. But we identified 4 priorities for the state of Illinois. We have infection prevention infrastructure, standards, and practices, assessment, treatment, and outbreak preparedness and response, antimicrobial stewardship, and multi-drug resistant organisms, which are kind of those special interventions that are tied to a specific bug. And then rather than have these as separate priorities like we kind of did in our old plan, which I don't know, how many people ever actually looked up our old strategic plan? Did anybody ever? It was kind of a template that was handed to us, and that was part of why we didn't feel like it was that useful. It was us filling out a template for CDC for funding. This was really our own creation. So we included education and training as one of our key strategies that's woven throughout the plan, as well as policy development, data and surveillance, and communication. And then we also have goals under each of the priorities. Antimicrobial stewardship actually has 2 goals. That goal 3 is improve antimicrobial prescribing practices across all healthcare settings. And then we made a separate goal for raising public awareness about antibiotic use and misuse. So it's really a substantial part of our plan. There we go. So again, along the theme of how we're using the data that we're getting, we started this project to present a facility-specific report using data that we've already reported on the Illinois Hospital Report Card to kind of take a different way of looking at this. And some of this stemmed out of a work group that I was part of on the Council of State and Territorial Epidemiologists. For those of you in hospitals that use kind of a stoplight system on some of your reporting things, getting this red X that says worse was actually a really contentious piece of this, to have that be a national standard of how we would help people interpret data. Because again, the SIR doesn't really speak to everybody. Some people really need it kind of put to them in very plain language, that statistically that number is worse than a different number. And lower or higher can be good or bad depending on which metric you're talking about. So we really wanted to have something that was a lot clearer. The other thing that we did that was a little different than the standard reports that we put out on these facility-specific reports is that we compared them not to just the national baseline, which the SIR already does that. Above 1 is worse, and below, statistically below 1 is better. But we compared them to whether or not they were better or worse than the state average for the same time period. So not just are you better or worse than the national baseline from whenever that was set, but are you better or worse than Illinois as a whole right now? And then we also trended them over time with just straight rates without any adjustment compared to the state rate. And part of why we did this is we have a large number of small hospitals in Illinois that their numbers are so small that we actually can't even calculate a standardized infection ratio. And so kind of what do you do with that? Again, the purpose of doing that kind of more abstract metric also is to adjust for facility type and other types of things. And we kind of felt like, well, if you're comparing them to themselves over time in a trend and just presenting the state aggregate to show what the statewide trend was over time just as kind of a reference point, you don't really need that statistical adjustment for that purpose. But so that they can see, well, maybe you're better than the state average, but if you're getting worse than you did the last year or two over time, that should be an early warning sign that you're not holding your ground in that kind of good position as well. And the other thing we put on these reports was the number of FTE equivalents of infection preventionists per 100 beds in the facility. And we put a little footnote in there about this 2002 report that recommended, IP staffing of 0.8 to 1 per 100 beds, which is really outdated. And I'm really hoping that the mega survey that APIC did about infection preventionists in hospitals and what their new role is like with all this expanded reporting, there's really been a whole sea change since this 2002 recommendation came out. So we're hoping that we'll get a better handle on what infection prevention staffing should look like, but to help put it in context that if they're woefully understaffed with their IP, even by a 2002 standard, and then it shouldn't be such a surprise if they don't see good rates in their infections. So we were helping to provide a little context with that IP staffing data. And we sent these reports out to 182 hospitals. 152 of them completed a follow-up survey. I think the bigger hospitals were a little less impressed because they run reports on themselves almost on a weekly or monthly basis anyway. But 49 hospitals said that they were prompted by the report itself to take action to reduce HEIs, including enhancing antimicrobial stewardship programs. And that, I felt, was really rewarding and really worthwhile of our efforts to put out a report like that. And future reports were talking about modifying, and we might summarize some things, some additional measures on there, like the NHSN survey responses regarding core elements of stewardship. And I've even heard back from some people that were invited to a special initiative where we said, hey, your NHSN survey data say that you don't have all these elements in place. The pharmacist at that facility might be surprised that that was what was put into that survey. So kind of showing that there's not always great communication between the IP and the rest of the team members dealing with this issue. We have a number of different initiatives that are going on to promote and track antibiotic stewardship and prevent resistance. First, we're trying to expand the reporting to that NHSN Antibiotic Use and Resistance Module. We have the Precious Drugs and Scary Bugs outpatient campaign, which Suzanne and Chinieri are really spearheading that effort. So I apologize that I've talked a lot about acute care settings because that's where we have a lot of the current data right now, but we are making a big push into outpatient care as well. We also are looking into trying to leverage long-term care pharmacy data on antibiotics by working a bit with the prescription monitoring program in Department of Human Services. And so I've applied for some funding to try to leverage their program and expand that. We have the Catalyst for Antimicrobial Stewardship Improvement Project, or CASI. And in fact, I think we have a special session about that later today. And then more generally, we also have the Infection Prevention Liaison Program, which is a quality improvement assessment and expert consultations from APIC Consulting, which we're doing in partnership with Chicago Department of Public Health and APIC Consulting, again, through a grant from CDC, kind of under this Ebola preparedness mindset. But, you know, I said right from the outset, we're going to do the zombie apocalypse model, which is kind of a rare instance of the federal government having a sense of humor. You know, if you're prepared for zombies, you're prepared for, you know, natural disasters, bioterrorism, whatever. Well, if you're prepared for Ebola, you're prepared for anything. And really, it's, you know, it's not just about that, but having a really solid infection prevention infrastructure across the board so that we have early identification and just good practices all around. So the idea being that we're trying to target facilities that seem like they could use a little bit of expert consultation and basically providing that for free through APIC Consulting for a limited time. So if you do get approached, I really encourage you to take advantage of that. And then we have enhancements going on with the XDRO registry. We have, and I don't think I have a slide about this, but we've started the auto alerts in a number of facilities and have found that about a third of the, you know, when a patient is admitted to one of these facilities, it has the auto alerts on. I think about a third of them did not know that the patient needed to be on contact precautions. And so it's enabling them to really isolate these patients a lot quicker and contain the spread of CRE. And then also ego network analysis, which is a really fancy way of statistically looking at not just facilities that are connected by geography, but connected by patient sharing networks. All right, and so now I'm at my post-test questions, which I guess I'll repeat for the CEs. True or false, in 2015, the number of people treated in Illinois hospitals with C. diff infection would be more than the capacity of the large outdoor concert venue at Millennium Park in downtown Chicago. And then which of the following are priorities of the Illinois Action Plan to prevent healthcare-associated infections and antimicrobial resistance? Infection prevention infrastructure, standards and practices, assessment, treatment, and outbreak, antimicrobial stewardship, multi-drug resistant organisms, or all of the above. Thank you, and I've got my contact information up there. The dph.dpsq email address usually gets a quicker response per